So let's talk about the differences between the pediatric neurologic system and the adult neurologic system. So as you know, brain, spinal cord, and nerves are all the major structures that make up our nervous system. And any alterations that take place in neurologic function can have widespread effects on the body's metabolism, as well as basically the body's function. We need our nerves to essentially talk to areas of our body so that body processes can take place, movement can take place, and general body function. The neural tube is the tube from which the brain and spinal cord form and develop during gestational growth. That occurs in utero in the first trimester of pregnancy. And we mentioned a little bit when we talked about iron deficiency anemia about the importance of having iron in the diet in adequate levels or appropriate levels in the pregnant mother to ensure that we have good neural tube development. So while that has taken place and completed during intrauterine growth, at the time of birth, the central nervous system is still somewhat immature, and maturation will continue to occur long after birth. So myelinization is the process by which speed and accuracy of the nerve impulses will take on better function. So things will get much more accurate in terms of our nerve endings talking, if you will, to one another. And that continues after birth, and it occurs in a cephalocaudal direction. And we've talked about that, how it's cephalocaudal growth and development as we progress through the age. And this is what enables children to slowly and progressively develop fine and gross motor skills. And again, we've talked about that when we talked about pediatric growth and development. So there are some basic structural differences, and this slide just shows a couple of them that are important for us to think about when we think about neurologic function. So remember that the infant is really considered top-heavy. Their heads are a lot larger proportionately to their bodies, and their neck muscles are still not well developed. So that means that they have a top-heavy status such that they can have a great deal more head injury, for example, through something like a shaken baby syndrome, because the neck muscles are unable to support the size of the head. In the adult, of course, or in the older child, we see that their heads are much more proportionate and have much more developed muscles for us. There is also a lot more spinal mobility in infants because they have still immature development of muscles and ligaments in that cervical or C-spine area. So that can also lead to potentially more injuries in that area of the body because of that lack of full development yet. So here's just a picture once again of the child's skull and fetal skull, and it shows those suture lines and those fontanelles, which we are always assessing and remembering that they close at different times, posterior closing earlier and anterior closing by no later than 18 months. Brain development will continue through puberty, and that is important for us to think about. We certainly know that sometimes risk-taking behaviors are the result of just not having full and complete brain development. So let's talk quickly about how we do a neurologic assessment in a child. Much of it is similar with just a few additions and corrections from what you learned in health assessment. We are certainly looking at level of consciousness of the infant when we are assessing them. Are they easy to arouse? Are they easy to console when they're crying? We will look at a Glasgow-Coma scale if we are concerned. Cognitive development, this is where it's so important to know our milestones and our developmental milestones, our verbal milestones, because we will be assessing, has the child reached those levels or not? We will assess cranial nerves, remembering that we will do that with the developmental level of the child in mind. We will look at the skull, feel for suture lines, feel for those fontanelles. Are they present or not? And should they be present or not, depending on the age of the child? Are they bulging? Are they sunken? Those can tell us give us various different pieces of information when assessing. We will look at pupils to see about reaction to light and accommodation in them. Size of those pupils is important as well. Additionally, vital signs and looking for any vital sign changes, because with something like increased intracranial pressure, we will see vital sign changes. We'll look at reflexes. When reflexes are present in that newborn period, we will assess those initially to determine the status, neurologic status of our infant. We will watch the children play and walk and run and move around and watch to see, do they favor one side or another? Is one side stronger than the other? Do they always use one side more than the other? We look for neck stiffness, and in particular, we're looking at nuchal rigidity, which we will talk a little bit more about when we talk about meningitis, but that is a classic sign. And then any family history of something like a headache or a seizure disorder would be something we would want to know when we were assessing the child. This is a modified Glaxo-Coma scale for infants and children, and this would be something that we would be referring to should we be scoring an infant or a child where we have some concerns about neurologic compromise. So additionally, when we are looking at posturing and movements, we do want to pay attention to decorticate or decerebrate posturing, which can be indications of severe brain injuries above the brainstem or at the brainstem. So decorticate or rigid flexion, and you can see that young boy there has the arms flexed inward, is associated with brain injury above the brainstem. And decerebrate posturing is rigid extension. So you see his arms now are at his sides and very rigidly at his sides. Those are associated with brain injuries of the brainstem. And finally, let's talk a little bit about increased intracranial pressure. That is a sign or an effect that we often see with many neurologic conditions. And we want to be able to recognize the signs of increased intracranial pressure in children. And so what we will see, if it's an infant, we won't be able to know whether they have headaches or visual disturbances per se, but we may see vomiting, we may see pupils that are not as reactive to light, and in infants and young children, sunsetting eyes. And you can see those pictures there are children with sunsetting eyes where the sclera is very visible above the iris. We may see that the infant is restless and hard to console. The infant would also potentially have a bulging fontanelle, wide sutures, so the suture lines in the skull may have separated a little bit more to accommodate the increased intracranial fluid and pressure. The head circumference may rise, and they may have a high-pitched cry. I often associate high-pitched cries with neurologic dysfunction. We will in class listen to a recording of a high-pitched cry so that we have some indication of what that may sound like. But we usually associate a high-pitched cry in an infant with a neurologic condition, such as increased intracranial pressure and meningitis, but also with young infants who are withdrawing from maternal drug use. Late signs of intracranial pressure increases would be a loss of consciousness or a change in level of consciousness, and of course then seizures. We also may see what is referred to as the Cushing's triad, and in that we will see irregular respirations, we will see bradycardia, and we will see an increase in the systolic blood pressure. Those three things are referred to as the Cushing's triad and are a grave and late sign of increased intracranial pressure.